Hello again, it's Dr. Harim Jaffer. I am periodontist and I am about to continue the series of lectures on periodontology. Before I start, I'd like to ask you to subscribe to my channel HL Talent to get more videos on this subject. So, in the previous lecture, we talked about the new classification of periodontology, and today we are talking about one of the most popular diseases in periodontology, which is gingivitis. We know that periodontium composed of gingiva, periodontal ligament, cementum, and alveolar bone. Simply, gingivitis is the inflammation of the gingiva without affecting cementum, without affecting the periodontal ligament, and without affecting the bone. So it's confined to gingiva. My agenda in today's lecture: first of all, pathogenesis, second, classification, then stages of gingivitis, clinical features. Then we have two main types of gingivitis, which are the most common types: plug-induced gingivitis or biofilm-induced gingivitis with or without local contributing factor. And finally, we have gingivitis due to systemic conditions, which we may talk about it later. And after all, we will discuss the management simply, how we manage the gingivitis case. So, we have pathogenesis and classifications. In the pathogenesis, especially as we talked about, the plug-induced is the most common one. There is increase in number of normal flora organism, especially Streptococcus, Capnocytophaga, and Actinomyces. These are types of bacteria that most predominantly seen in plug-induced or biofilm-induced gingivitis. These grow in the gingival crevice, producing toxins that can cause inflammatory reaction in the gingiva. The plug or bacterial aggregate accumulate in the crevice, resulting in inflammatory reaction, and the complication may lead to development of periodontitis. So untreated gingivitis may progress to periodontitis. Regarding the classifications, we have two bases on which we classify the gingivitis. One of them is according to the course and duration. The second one according to the distribution of the disease. In the first one, according to the course and duration, we have acute, recurrent, and chronic gingivitis. Acute gingivitis, it's of sudden onset and of short duration and can be painful. But a less severe form of acute gingivitis had been termed subacute. And sometimes you find out that there is pain, but not so severe. So in these cases, we may use the term of subacute gingivitis. In case of recurrent gingivitis, it reappears after having been eliminated. So you treat the gingivitis, and soon it will reappear after the treatment. So this type is called gingivitis, recurrent gingivitis, or relapsed gingivitis. We have chronic gingivitis. As we know, all the chronic forms of disease are slow in onset and is of long duration. It's painless unless it's complicated by acute or subacute exacerbation. So all of the chronic inflammations are painless until it will undergo an acute exacerbation. So this is according to the course and duration. According to the distribution, we have 5 classifications: localized gingivitis, generalized gingivitis, marginal gingivitis, papillary gingivitis, and diffuse gingivitis. In localized one here, for example, as this picture, it's confined to the gingiva of a single tooth or a group of teeth. For example, it affects 1 tooth or 4 teeth, 3 teeth, or separate, for example, single or multiple teeth, for example, 2 teeth here and in another quadrant, 2 teeth to another teeth. So this is localized, and we have an outline or boundary for localized lesions. Less than 30% of the gingiva affected is localized. More than 30%, it's generalized. Generalized gingivitis, it's almost affecting the oral cavity or the entire mouth, not specifically each single surface area of the gingiva, but it's actually affecting more than 30% of the surfaces of the gingiva. We have marginal gingivitis. Marginal gingivitis, as it's here, it's generalized, but also it's marginal. Here we see that a marginal gingiva is involved, and it may involve a part of the attached gingiva. So not just the marginal gingiva or free gingiva is affected. So it extends partially to the attached gingiva. So this is marginal gingivitis. Papillary gingivitis, it involves the interdental papilla here and often extend to the adjacent portion of the marginal gingiva. The effect here, and because it's inflammation, it crosses, for example, from this papilla and this papilla, and while crossing, it will affect the free gingival margin. So we may have a marginal gingivitis, for example, plus papillary gingivitis at the same time. We may have generalized gingivitis, but at the same time it's marginal gingivitis. At the same time may involve the papillary gingivitis one. In case of diffuse gingivitis, it involves the gingival margin, like you see here, the interdental papilla here, and the attached gingiva. Also the attached gingiva all are included here. So in the diffuse, it's simply just like marginal gingivitis, but involving a wider area of the attached gingiva, like you see here. Almost all the attached gingiva are included. So this is according to the distribution. Here we finish the classification. We are going to talk about the stages. In gingivitis, we have 4 stages. Stage 1, which we name it initial lesion, histologically. The first manifestation of gingival inflammation is vascular change here. We have vascular change, consisting essentially of dilation of capillaries and increasing in the blood flow. but there's no clinical signs appear in this stage. It occurs within 2 to 4 days of plaque accumulation. When you have a plaque 2 to 4 days not brushed, you may not have a clinical signs of gingivitis. You may not have redness or bleeding, but the inflammation is already started. So, if this is not treated, or you are not undergoing a good or proper oral hygiene care, you may face the another stage, which is early lesion, stage 2 gingivitis. In this stage, we may see usually this stage at 4 to 7 days of plaque accumulation. And here the clinical signs of erythema will appear. There will be a redness, and mainly owing to the proliferation of capillaries and increased formation of capillary loops between retipex or ridges, and the bleedings on probing may also be evident. So here there will be proliferation of capillaries, the gingiva will be more erythematic, more redness, and the signs of bleeding may appear during 4 to 10 days. If the early lesion is not treated by the daily oral care of the patient, the disease or the lesion may change or may shift to established lesion, which is the third stage of gingivitis. Here the lesion develops generally after 14 to 21 days of plaque accumulation. Here blood vessels become engorged and congested, venous return is impaired, and blood flow becomes sluggish. So you may see the gingiva is more darker in color. You may see congested bloods. So the established lesion can be described as moderately to severe inflamed gingiva. So after this lesion, the established one or the stage 3 gingivitis, you may shift to another aggressive and final stage of the gingivitis, which is the advanced lesion, which if not treated may lead to progression to periodontitis. So the advanced lesion is stage 4 gingivitis. The lesion here extends into the alveolar bone and known as the face of periodontal destruction. So if it's not stopped in the established one and it becomes an advanced lesion, here the plasma cells continue to predominate and there's a loss of alveolar bone will start from the stage, and there will be a breakdown of periodontal ligament and disruption of the gingival tissue architecture. So we must be aware of that. These are the 4 lesions: initial, early, established, then advanced. In the advanced, still advanced, till the advanced lesion, the disease could be reversible. But after that, when alveolar bone breakdown happen and more periodontal ligament breakdown will happen, so the disease will become chronic, irreversible periodontitis, or in the new term it will become a periodontitis simply. So these are the stages of gingivitis. We are coming to the clinical features. In the clinical feature, we may look for symptoms, colors, consistency, and enlargement of the gingiva. Regarding the symptoms, the earliest symptom of the gingival inflammation are increased gingival fluid production. and bleeding from the gingival sulcus on gentle probing. So, most of the time, as a new classification say, that bleeding on probing is the most visible and dependable criteria for deciding that this case is gingivitis or not. But it should involve more than 10% of the entire oral cavity, the gingiva we mean. Regarding the color, the gingiva become redder when there is an increase in vascularization or when the degree of epithelial keratinization is reduced. So there will be a loss of keratinization. The color becomes paler when vascularity is reduced and keratinization is increased. But in gingivitis, it's the reverse. The color may be sometimes reddish blue or deep blue. If venous status has occurred, if the venous return have a problem and you have congested blood, so most of the time you may see deep blue color. The color change starts in the interdental papilla, gingival margin, and spread out to the attached gingiva. The third clinical feature is the consistency. The consistency of gingiva may be spongy or flabby, that pits on pressure, and there may be marked softness of the gingiva. The gingiva becomes spongy actually. It will become flabby. You can reflect the gingiva by air syringe. So it loses its attachment. And regarding the enlargement, sometimes in inflammation there may be gingival enlargement, as you may see here, for example, here throughout the mouth. This case is generalized gingivitis actually, and it may lead to change in the contour of the gingiva. You see that there is no knife edge, triangle, well established gingiva. You may see a puffy, spongy, more rounded head gingiva, so it affects the shape and the contour of the gingiva. So this is the clinical feature. And now we are talking about the plug-induced gingivitis with and without local factors. When you talk about the biofilm-induced gingivitis without local factors, here we have a characteristic common to all plug-induced gingival diseases. First of all, we have signs and symptoms which are confined to gingiva. The presence of dental plug is crucial to initiate or exacerbate the severity of the lesion. There is clinical signs of inflammation like enlarged gingival contour due to edema or fibrosis, color transition to a red or blue-red, and due to elevated cellular temperature, and bleeding upon provocation or probing, and there is increased gingival exudate. Another characteristic is clinical signs and symptoms associated with a stable attachment level on a periodontium with no loss of attachment, or on a stable but reduced periodontium. In all plug-induced or biofilm-induced gingivitis, there is no attachment loss. A case to become a gingivitis, there shouldn't be an attachment loss. Or there is a stable disease, which is a treated previously present periodontitis. And today we have gingivitis upon reduced periodontium, which we mentioned on the new classification. So either it will be the sign of gingivitis, it will be without attachment loss or on a reduced periodontium, but stable periodontitis, which has a more than 10% bleeding throughout the mouth and a pocket of 4 millimeter or less with no bleeding or probing inside the pocket. The disease should be reversible, another characteristics, by removing the etiology. So these characteristics are common to all plaque-induced gingival disease. Okay, now we are talking about the biofilm-induced gingivitis with local contributing factor. What do you mean by local contributing factor? Are the plaque retentive factors. One of them are teeth anomalies. Teeth anomalies such as enamel peel and cemental tears can modify or predispose to plaque-induced gingival disease. Enamel peels are found in, for example, 1.1 to 5% of molar teeth, and maxillary second molar are the most commonly involved. We have dental restorations. The subgingival margin of restoration and violation of biological width can affect the health of adjacent gingival tissue. For example, we have an overhang filling. We have ill-fitted restoration, which may affect the periodontium, especially in those who went subgingivally. We have root fracture. In case of root fracture and root perforation due to endodontic therapy, these always associate with inflammation of the gingiva and sometimes pocket formation due to enhanced plaque accumulation. And finally, in cervical root resorption, we have cervical root resorption may result in inflammation, particularly when a communication is established with the sulcus. So in this case, you may find a cervical resorption, and most of the time this will lead to gingival recession and subsequent inflammation. Other causes we may have, for example, deep bite. These are local contributing factor, nor the causative factors in inducing gingivitis, in progressing the inflammation of gingivitis. So we have deep bites, palatogingival grooves, and shallow vestibules also may lead to gingival inflammation. So this is about the biofilm induced gingivitis, both local factors and both who the local factors are contributed, and as general all the plaque induced gingivitis. Then we are going to gingivitis due to systemic factors. We have systemic factors, or in another way, we have another classification of gingivitis, which we may write it down during diagnosis. These are the systemic factors which are contributing to gingivitis. For example, 3 of them mainly associated with the hormonal change. We have puberty associated, we have menstrual cycle associated, and we have pregnancy induced. In the puberty associated, it appears to be exaggerated response from the gingival tissue toward high levels of hormone, especially estrogen and testosterone, secondary to plaque accumulation. While in menstrual cycle associated gingivitis, although bright red hemorrhagic lesions have been described prior to the onset of menses, clinically detectable changes do not seem to be associated with the menstrual cycle. However, an increase in gingival crevicular fluid, by 20% has been described in 70% of women during ovulation. So increase these gingival crevicular fluids indicate that there's a response to a present inflammatory process. While in pregnancy-associated gingivitis, the exaggerated response of gingiva to local factor can often appear during the second trimester and progress upon parturition. The condition can be reversed with suitably high level of plug control. Pyogenic granuloma of pregnancy is a localized mass of highly vascular tissue arising as an exaggerated response to plaque. It commonly arises from the proximal gingival tissue and has a pediculated base, and it may show ulceration of its thin epithelial lining, and bleeding on mastication or spontaneously may be a present complaint. The pregnant lady may complain from bleeding on mastication or spontaneous bleeding. So these are maybe the pyogenic granuloma, and the bleeding may be the chief complaint of the pregnant lady. Here we come to the diabetic patient. Diabetic associated gingivitis. There is evidence that type 1 diabetes in children is associated with gingival changes. However, when this type of diabetes is under good control, the gingival inflammation is less exaggerated. So it's not so common, but this is how it works. We have leukemia-associated gingivitis. The leukemia has been associated with gingival changes, including the gingival swelling, redness, blueness, sponginess, and glazed appearance. The leukemia most commonly associated with gingival changes, acute myeloid leukemia. Any other condition affecting the platelet deficiency can affect periodontium. This is to be obvious. Cyclic neutropenia, a condition characterized by fluctuation in neutrophil counts with a periodicity of 14 to 36 days, is associated with oral ulceration and exaggerated gingival response to dental plaque. We come to drug-influenced gingivitis. The increased use of oral contraceptives by postmenopausal women has been associated with a higher incidence of gingival inflammation and development of gingival enlargement. This phenomenon can be reversed by discontinuation of medication. Lastly, from systemic factors is ascorbic acid deficiency. Severe vitamin C deficiency in humans results in scurvy, a disease characterized by hemorrhagic diathesis and retardation of wound healing. The clinical features include bleeding, swollen gums, and loosened teeth. Scurvy results in defective formation and maintenance of collagen, retardation or cessation of osteoid formation, and impaired osteoblastic function. It's also characterized by increased capillary permeability, susceptibility to traumatic hemorrhage, hyporeactivity of the contractile elements of the peripheral blood vessel, and sluggishness of blood flow. So these are the systemic factors that are associated with the formation of gingivitis. Lastly, we have here the management of gingivitis simply. The management of gingivitis including removal, because it's reversible actually. The treatment is simple. We have removal of local irritant. It should be completely removed. For example, it's fish bone, it's a piece of metals, it's a traumatic abrasion, anything should be removed. And it should be seized, for example, if it was a habit that's causing gingivitis. Plug control, thorough plug control should be done with scaling and polishing, because our main causative factor is bacteria, it's plug, it's biofilm. And mouthwashes are of short-term basis actually, are of great importance if you have gingivitis, but of short-term duration. For example, for 1 week you are using a specific type of mouthwash containing chlorhexidine. It may not affect your health and not causing any stain during 1 week, and it will be better for resolving the gingival inflammation. And this is the last topic of today's lecture. I hope you enjoy it, and please don't forget to subscribe to my channel. Have a nice time and good luck for all you, and hope I see you again in the next lecture.